Welcome to our second video on inflammatory bowel disease. In this lecture, we will cover Crohn's disease. Let's begin. We will address the definition, risk factors, clinical presentation, diagnosis, and management of Crohn's disease. Crohn's disease is a chronic, relapsing, remitting inflammatory disease causing transmural inflammation of the gastrointestinal wall. Importantly, it can affect any part of the bowel wall, from mouth to anus, but most often it affects the terminal ileum. This cartoon depicts the area of gastrointestinal tract that can be affected by Crohn's disease. Note that any part of the bowel can be affected from mouth to anus. Also notice that there are spaces of unaffected bowel in between. Let's move on to risk factors. The important thing to know here is that tobacco smoking is a risk factor. Smokers have a higher risk of developing Crohn's disease, and it increases the risk of complications and the need for surgery in those with established Crohn's. This is in contrast to ulcerative colitis, where tobacco smoking decreases the risk of disease. However, similar to ulcerative colitis, those who are positive for the HLA-B27 allele have higher chance of developing Crohn's. We'll discuss the clinical features of Crohn's disease by talking about the intestinal features, followed by the extra-intestinal features and complications. One main presenting feature is non-bloody diarrhea. This, in fact, distinguishes it from ulcerative colitis. The inflammation can also lead to the formation of intra-abdominal fistulas and strictures. Another presenting feature is perianal disease, which can include perianal abscesses, fistulas, and anal fissures. It's important to remember that fistulas are a common feature of Crohn's disease as opposed to ulcerative colitis. These two cartoons illustrate the common patterns of perianal fistulas and abscesses formation. On the image to the left, the blue line shows several connections that can be created between the rectum and perianal skin. The right image shows areas of green, which are common areas of perianal abscess formation. Let's move on to extra-intestinal features. Since Crohn's disease can affect any part of the bowel, even the mouth, patients can develop aphthous ulcers, also known as canker sores. Because of the inflammatory nature of the disorder, a low-grade fever may be present. Actually, Crohn's disease shares many extra-intestinal features with ulcerative colitis. Inflammation of the eyes can cause uveitis, episcleritis, and scleritis. The two common rashes are erythema nodosum and pyoderma gangrenosum. Also, the patients often complain of joint pain due to arthritis. Here's an image showing an aphthous ulcer. It's usually described as having a gray base surrounded by erythema. Aphthous ulcers are not specific to Crohn's disease and are very common among the general population. However, they can be the first mucosal lesion to develop in Crohn's disease. Now we will touch on the complications. Although the diarrhea is usually non-bloody, microscopic bleeding can occur and lead to iron deficiency anemia. Patients are also at higher risk of colon cancer compared to the general population. It's also very common to develop cholesterol, gallstones. These are thought to be caused by impaired bile acid absorption, which leads to bile that's oversaturated with cholesterol. This causes the cholesterol to precipitate and form stones. The impaired bile acid absorption in terminal ileum can also result in fatty acid malabsorption and steatorrhea. Calcium oxalate kidney stones are also often seen in those with Crohn's disease. Another complication is vitamin B12 deficiency. This occurs because vitamin B12 is normally absorbed in the terminal ileum, and the terminal ileum is often affected in Crohn's disease. Vitamin B12 deficiency leads to a macrocytic anemia along with neurologic manifestations. A 25-year-old woman comes to the physician due to an intermittent abdominal pain for the past year. Her stool is fatty and difficult to flush. The physical exam reveals perianal fistula. The patient had 5 episodes of nephrolithiasis over the past year. What's the most likely pathophysiology of this patient's predisposition to kidney stones? This young woman reports an intermittent abdominal pain for the past year. Her stool is fatty and difficult to flush, which is a sign of fat malabsorption. The physical exam reveals perianal fistula. Intermittent abdominal pain, fat malabsorption, and the perianal fistula are consistent with the diagnosis of Crohn's disease. The patient had 5 episodes of nephrolithiasis over the past year. Let's explain the pathophysiology of recurrent kidney stones in patients with Crohn's disease. Oxalate is normally bound to calcium in the bowel. However, calcium has a higher affinity for lipids than oxalate. When terminal ileum is affected in Crohn's disease, fat malabsorption occurs and the intestinal calcium binds to lipids in the lumen. Therefore, oxalate remains unbound. It is absorbed from the GI lumen into the blood and filtered across the glomerulus. Oxalate in the kidney tubules then binds to calcium to form the calcium oxalate kidney stones. This is a cartoon of the terminal ileum where it connects to the cecum. Vitamin B12 and bile acids are normally absorbed into the bloodstream at the terminal ileum. In Crohn's disease, absorption of these two substances is impaired, and this can lead to vitamin B12 deficiency and cholesterol gallstones, as we previously explained. This is a reminder of what calcium oxalate crystals can look like. Some crystals have a characteristic envelope appearance because the X in the middle of the crystal looks like the folds on the back of an envelope. Other calcium oxalate have a dumbbell appearance, like the one shown here. Diagnosing Crohn disease begins by recognizing the clinical signs and symptoms. Complete blood count typically shows leukocytosis. Elevated inflammatory markers such as an elevated erythrocyte sedimentation rate is also a potential but nonspecific finding. A positive anti-Saccharomyces cerevisiae antibody, or ASCVA, is associated with Crohn disease. This association is weak, and the presence of antibody cannot be used to give a definitive diagnosis, since it is neither sensitive nor specific. However, ASCA can help differentiate Crohn's from ulcerative colitis. Imaging, such as an abdominal X-ray, is often ordered. The two common findings are strictures and fistulas. A stricture means there is a narrowing of the lumen of the bowel wall. This is often referred to as a string sign when seen on fluoroscopy using a radiocontrast dye. A fistula is an abdominal connection between two or more epithelialized hollow spaces or organs. Colonoscopy and biopsy are used to make a definitive diagnosis. Colonoscopy will typically show nodularity and normal mucosa separated by ulcers that are serpiginous or linear. This is often referred to as the cobblestone appearance. There are also areas of unaffected bowel between areas of inflammation. The areas that are unaffected are called skip lesions, and they are a supporting finding of Crohn disease. Obtaining a biopsy can reveal two histologic findings that are very characteristic of Crohn disease. The first and most distinguishing one is the presence of non-caseating granulomas. Second, if a sample of all layers of the bowel wall were taken, it would show transmural inflammation, meaning that Crohn disease causes inflammation of all layers of the bowel wall. This is a fluoroscopic image, and here we see the ileum. This is the cecum, and this is the ascending colon. Before the ileum reaches the ileocecal junction, it constricts, resembling a string. This area of the bowel is very commonly affected by Crohn disease. Here's an example of the cobblestone appearance that can be seen in Crohn's. Please notice the areas of nodularity and normal mucosa that are separated by these serpiginous or snake-like ulcers. Here's a histologic image to remind us of what a non-caseating granuloma looks like. Remember that a granuloma is a nodular collection of macrophages, epithelioid cells, and multinucleated giant cells. The granuloma is surrounded by fibroblasts and lymphocytes. The term non-caseating means that there is no necrosis in the center of the granuloma. A 38-year-old man presents to the physician due to intermittent constipation and abdominal pain for the last 6 months. He denies the presence of blood in his stools. The physical exam shows several aphthous ulcers in the mouth and painful red nodules on both shins. Colonoscopy with biopsy is performed. What will likely be found on the histologic exam of this patient's biopsy specimen? The patient presents with intermittent constipation and abdominal pain for 6 months. He denies presence of blood in his stools. Physical exam shows several aphthous ulcers in the mouth, as well as painful red nodules on both shins consistent with erythema nodosa. All these signs and symptoms point to the diagnosis of Crohn's disease. The biopsy specimen from the patient with Crohn disease typically shows non-caseating granulomas and transmural inflammation. Managing Crohn disease has many similarities with managing ulcerative colitis. We'll point out some important differences in the next couple slides. Treating acute exacerbations of Crohn disease involves using sulfasalazine, topical or oral corticosteroids, and maybe anti-TNF agents. For the maintenance therapy, we use sulfasalazine anti-TNF agents like infliximab and adalimumab, as well as azathioprine. Medical therapy sometimes fails, and in such cases, surgery can be performed. Some surgical options include partial bowel resection, draining abscesses, and performing balloon dilation to open the constricted bowel. Remember that smoking increases the risk of complications and need for surgery. Therefore, patients who smoke should be advised to quit. Finally, individuals with Crohn disease are at higher risk of developing colon cancer. For this reason, screening regimen for patients with this disease is different from the one recommended for the general population. Those with Crohn disease should receive a colonoscopy 8 years after their diagnosis and every 1 to 3 years thereafter. Let's end the lecture with a question. A 25-year-old man presents to the physician due to severe anal pain for the past week. His past medical history includes frequent bowel movements with fatty stools. He's been smoking 1 pack of cigarettes per day for 7 years. His vital signs include temperature of 39 degrees Celsius, blood pressure of 120/75, heart rate of 92, respiratory rate of 15. Physical exam reveals perianal fistula, draining pus. Ophthalmologic exam shows bilateral conjunctival injection with dilated episcleral blood vessels. The patient is treated with antibiotics. After finishing antibiotic therapy, he undergoes colonoscopy with biopsy that shows non-caseating granulomas with transmural inflammation. Which of the following is the best strategy for colon cancer screening in this patient? A. Start screening now and repeat every 3 to 5 years. B. Start screening 4 years after diagnosis and repeat every 3 to 5 years. C. Start screening 8 years after diagnosis and repeat every 1 to 3 years. D. Start screening 10 years after diagnosis and repeat every 1 to 3 years. This young man presents with severe anal pain for the last week. The physical exam reveals perianal fistula draining pus. His past medical history includes a frequent bowel movement with fatty stools consistent with fat malabsorption. Ophthalmologic exam shows bilateral conjunctival injection with dilated episcleral blood vessels. This suggests the episcleritis. Colonoscopy with biopsy shows non-caseating granulomas with transmural inflammation. All these findings are consistent with the diagnosis of Crohn disease. The best strategy for colon cancer screening in patients with Crohn disease is to start screening 8 years after diagnosis and repeat every 1 to 3 years. So the correct answer is option C. Here's a slide reminding us of the strategy for colon cancer screening in patients with Crohn disease. As we already mentioned, the colon cancer screening in patients with Crohn disease should start 8 years after diagnosis and repeat every 1 to 3 years. This is why options A, B, and D are incorrect. And that concludes our lecture on inflammatory bowel disease.